Hi, Dr. Horn with infectious disease. So today we're going to be talking about GI illnesses. This was a request that we had. Somebody asked for us to talk about GI illnesses, and I think this is a good topic, especially now. And it seems like a lot of people are getting sick with not only influenza and upper respiratory, but also uh, GI illnesses. And this, as far as GI illnesses go, it's a very big topic. I am going to concentrate mainly on acute infectious diarrhea because that's what we see in infectious diseases. And so, that's going to be the main focus. This is not intended to be an uh, completely comprehensive discussion since diarrhea in itself is such a large topic and infectious diarrhea is a large topic. So we're going to try to hit the main points, try to hit the stuff that I feel like is the most important. So we're going to kind of do kind of an overview of the topic. And if anyone has any questions, you can always write questions in the chat or email me separately. And we're going to get into it. This is a very good article, Acute Diarrhea in Adults. This is very good. I do have the information here. It's American Family Physician. It's 2022, and it's very good. You'll see a lot of the algorithms and images that I have are going to be from this article. I really like this article, and I really like showing diagrams and pictures. I think that's, for me, the best way to kind of look at things would be, knowing the images in the article, and the article. So this is where I got a lot of them. And the impact of diarrhea, it's acute diarrheal disease accounts for 179 million outpatient visits annually in the United States. Acute GI infection is very common. Diarrhea is the most common manifestation. Worldwide, it's particularly common, especially in children, up to 50% mortality by age 7 in some parts of the world. So it's just to emphasize the impact, but I think we all kind of know the impact because we see it so frequently, not only in the hospital, but just overall. Characteristics of diarrhea. So it's important, when someone says I'm having diarrhea, the question is what do they mean, right? So um, people they might say they're having diarrhea and they might mean different things. Do they mean they're just having a lot of stool? Do they mean they're frequently having stools just throughout the day? Is there blood? What is the duration? The duration is a particularly important one because there are algorithms to try and figure out what type of diarrhea they're having, and there's acute and persistent and chronic. And knowing that, it helps to, try to figure out what type they're having. And the workup can change depending on if it's acute or persistent or chronic. So acute is less than 2 weeks, so it's less than 14 days. Persistent is 14 to 29 days, and chronic is greater than 30 days. So this is important for me also because acute infectious diarrhea, viral or bacterial, usually self-limited. So chronic diarrhea is usually not from an infection. Um, and that's important because from my standpoint, I'm infectious disease. Is it infectious or not infectious? And if it's been going on a really long time, longer than 30 days, but if someone comes in and says they've been having diarrhea for 2 or 3 months, more than likely it's not going to be infectious. So this can help to kind of, um, when you're looking at your algorithm and you're looking at your differential, help kind of narrow things down. The history should include onset and frequency of symptoms, stool character. Are they having a fever, other symptoms? But do other people have the same thing? So any sick contacts, are other people sick? Recent food consumption. So uh, we'll talk about food poisoning and getting sick from food. Have they recently traveled? So we wouldn't be testing ova and parasites if a person hasn't traveled, or we wouldn't be testing ova and parasites if a person has been um, in a nursing home, hasn't traveled. So it's important to kind of conserve resources, and if we don't need to check ova and parasites, then we wouldn't be checking. And Are they immunosuppressed? Are they on antibiotics, laxatives, other drugs? Is it medication-induced diarrhea, surgery, hospitalizations? These are all things you want to ask the patient. Now, infectious versus non-infectious. So this is the most important thing when it comes to me, is I'm saying, do they have an infection or not? And if it's not an infection, um, I will sign off. I will try to figure out what they have, but my main goal is to figure out if it's infectious or non-infectious, and then kind of go from there. There's an old saying that says, make your own mistakes. So if someone comes in and they have diarrhea, say they're transferred from another facility, or the patient comes in and says, I have diarrhea from C. diff or from something, it's important to not only look into that and see if that is the cause, but also, um, you know, could they have something else? And it's possible to have two different causes. Usually it's just one, but sometimes people come in and they'll say it's from C. diff, or if a patient is transferred or there's a handoff and they say the patient has C. diff diarrhea. Oftentimes, I'm kind of concerned due to anchoring. It's one form of bias. So there's an anchoring bias where everyone will say, oh, that's what they have, and it gets passed down. They have C. diff diarrhea, and then people don't look into it anymore. And they'll say it's C. diff and stop looking, and they kind of anchor on a diagnosis. So that's what I mean by making your own mistakes. If someone comes in, you want to make sure that if you're making a mistake, you're making your own mistake. So I've had patients that they're told they have C. diff diarrhea, and um, they get treated for C. diff over and over and over and over again, and then they actually had pancreatic insufficiency as the cause, and they got pancreatic enzymes, and it went away. So, and that's what I mean by sometimes, you know, um, when people anchor, they just essentially stop looking. Now, common causes of non-infectious diarrhea, abdominal processes like appendicitis, ischemic colitis, malignancy, dietary, endocrine, functional, inflammatory, medication effects. So this is the most we're going to talk about non-infectious causes. So there are other causes besides infection for diarrhea, but these are some non-infectious causes. And then from here on out, we'll be discussing infectious diarrhea. Now, these are some of the things that you want to ask about, because there are links with some of these things. So there are associations. So hospitalization, childcare, international travel, immunocompromised animal exposure. And so these are when you get a history from the patient, a lot of times you can get a history, and without knowing certain things, you wouldn't be looking. So that's why I ask patients about animal exposure. Do they have pets? Do they live on a farm? I ask what they do for work to figure out what they're exposed to, and I try to get an idea of uh, a little bit about what they've been around. Now, these are some of the associated findings that I was just mentioning. So let's see. I'll get my laser pointer. Persistent or chronic diarrhea. So there are some infections that can be persistent or chronic. So Cryptosporidium, Giardia, Cyclospora, Entamoeba. Here are some things so it's not all chronic diarrhea is non-infectious. There are some. Now, if there's stool and blood, there are certain types of bacteria that can cause stool and blood. We'll talk about this a little bit more when we talk about inflammatory versus non-inflammatory. So non-inflammatory might be an example of something turning on a pathway to secrete more fluid into the lumen of the gut, but inflammatory would be more like pus and invasive into the side of the colon. And if it's invasive and it's causing damage to the colon, it could cause bloody diarrhea. So when you think blood and stool, that should kind of limit the things that your differential a bit to think about specific things. Are they having a fever? Sometimes people can have just straight diarrhea with no problems and get better, such as traveler's diarrhea, and it'll be self-limited and they'll get better. But um, are they having a fever? Are they having inflammation and inflammatory response? Abdominal pain is another one that some types of bacteria are known for causing abdominal pain, whether it's from cramping or other causes. Severe abdominal pain, awfully grossly bloody stools. Also, there's the likely pathogen there. Persistent abdominal pain, nausea and vomiting, diarrhea. Now, this, I don't need to go through all of these, but I wanted to also have this PowerPoint as kind of a reference. So, it's something to refer back to. You can say, oh, I remember we talked about this. These charts are from Infectious Disease Society of America. They are from 2017 from the guidelines. So if you go into Google and you type in IDSA diarrhea guidelines, it will pop up. And here's some more links, some more associations with exposure and conditions. So foodborne. This is, cruise ships. Everybody knows about norovirus and some of the more common ones. Consumption of unpasteurized milk, salmonella, brucella is another one. Raw undercooked meat or poultry. This is STEC. So this is E. coli 0157. So most people, when they get sick from eating food, most people get sick from eating vegetables more so than meat. But when they get sick, they don't get as sick as the cause of like E. coli 0157. So we make a big deal about when people get sick from eating beef and undercooked meat because the mortality is higher from getting sick from eating meat, but the frequency, people are more frequently sick from eating salads and vegetables. And that's why I don't eat vegetables. Okay. Consumption of fruits and or unpasteurized fruit juices, vegetables, and then here we have Cyclospora, Salmonella, Listeria. So about every year we'll see an outbreak of or every year, every few years, the CDC will report outbreaks of Listeria. Um, and that's, the outbreak investigators. Um, I don't know that we're going to be seeing this so much in the future because all of the first year outbreak investigators were recently fired. Um, which is not great. And a lot of the outbreak investigations may stop. So that's all I'll say about that. Consumption of undercooked eggs, Salmonella, Shigella, consumption of raw shellfish, Vibrio is the famous one. Exposure conditions. So swimming in or drinking untreated fresh water, Campylobacter, Cryptosporidium, Giardia. When people go hiking and traveling, Giardia is one of the big ones, especially if they're swimming in creeks and streams. Healthcare associated norovirus, C. diff, and exposure to house pets with diarrhea, Campylobacter. So these are some things, some associations to think about. Now, as far as age group, young children and infants get rotavirus. And as far as the clinical examination, so when you examine the patient, you want to make sure that you're looking for dehydration. Do they have sepsis or septic shock? Do they need a surgeon? Do they need a surgical procedure? So all patients with diarrhea, are they dehydrated? Are they able to keep up with it? Keep up with their fluid intake? And most episodes of acute diarrhea in countries with adequate food and water require only initial evaluation and supportive treatment. So most of the time, when people get diarrhea, it's self-limited. It goes away on its own. The patients get better, but you want to make sure they're hydrated. So different people have different recommendations as far as staying hydrated. Sometimes people will recommend something like taking Gatorade and alternating Gatorade and water, just because Gatorade has so much sugar that they don't want people to drink 10 Gatorades and just get too much sugar. But essentially, you should be giving people what they're losing. So you're replacing what they're losing. So if they're losing, what electrolytes they are losing, you want to replace those. Now, dehydration, the duration, inflammation, severe illness, hypovolemia, bloody stools, fevers. So now stool tests. So what tests should we be doing on the stool? These are options, we'll talk about when they make sense for different situations, but white blood cells, blood culture for enteric pathogens. So you could do a culture, microscopic examine for ova and parasites, toxin assays, and nucleic acid amplification. In our hospital, we use BioFire. We have a BioFire stool test, which looks for a lot of different things. There are benefits from doing PCR, and there are also benefits of doing stool cultures. One of the benefits of doing stool cultures, if you identify something and you're able to culture it, or if you're able to identify it by culturing it, then you can do a susceptibility test and see which antibiotics would work for it. Where with a PCR test, if you identify it, you may identify it, but you won't know which antibiotics would work. So there are pluses and minuses for each of the different types of tests and how to identify them. Endoscopy, this is a question we sometimes get. Would endoscopy be helpful? So putting a camera down into the stomach or putting a camera into the colon to look and to get biopsies, sometimes that's helpful. Generally, as I was saying earlier, the acute diarrheal illnesses get better and are self-limited. So if that's the case, then doing an endoscopy for something that's gonna be self-limited is a pretty big hassle. But for some things like CMV colitis, for CMV colitis, the way to diagnose it would be to get a biopsy of the tissue and send it to pathology, and they can look at it under the microscope for inclusion bodies. So you would need to do a a, uh, an, a colonoscopy with biopsy um, to diagnose CMV colitis, and that usually is in patients that are very immunosuppressed and transplant patients, and um, so at times endoscopy would be helpful. C. diff colitis endoscopy can be helpful. Ischemic colitis and immunosuppression. Now we're going to talk about a few specific cases. Traveler's diarrhea is a big one that we get frequently asked questions about. Food poisoning and hospital-associated diarrhea. So we're going to briefly touch on these. Traveler's diarrhea. So we have a travel clinic, and when people come to travel clinic, they'll tell us what countries they're going to, and then we'll discuss traveler's diarrhea because it's one of the most common um, infectious causes or infectious issues when people travel. So generally, the recommendation is that um, to try and eat and drink to avoid things that are going to give you diarrhea. So we recommend not drinking the tap water in some countries. Um, you know, not drinking the tap water. Um, there are countries that are identified or regions identified by the Yellow Book that CDC puts out as far as recommendations for travel. So if someone's going to Western Europe or Japan, Australia, there are some places that are people get diarrhea less frequently than other places. Um, but if you're traveling to Mexico or you're traveling to India, we recommend not drinking the water and drinking bottled water. And if you're gonna eat foods, divide people up into adventurous eaters and non-adventurous eaters. And uh, adventurous eaters are people that eat the street food, the food that's sold on the streets, and they're not as careful as someone that is, they drink the water or they brush their teeth with um, the tap water. Um, And so they're kind of divided up into different categories. And sometimes people, in some studies, even if the non-adventurous eaters followed all the recommendations, they got diarrhea more frequently than the adventurous eaters. So it kind of mixed up what recommendations to give. But uh, essentially, it's boil it or boil the water or peel it, cook it, don't eat it. So peel it being if you're going to eat vegetables or fruit, that is something that you peel. And when people travel, ETEC, enterotoxin genic E. coli, is the most common cause of traveler's diarrhea. So if someone is going to travel, what antibiotics would work for ETEC and what antibiotics would work in the different regions, right? So in the past, they used to recommend either azithromycin or a fluoroquinolone like levofloxacin or ciprofloxacin if a person developed traveler's diarrhea. Now it's recommended that people take azithromycin over fluoroquinolones because of all the resistance in these locations. So what we do at Travel Clinic is that we do a couple things. One, we recommend people take Imodium with them when they travel. So an Imodium is over the counter. So you could just take some Imodium with you when you travel uh, to these locations. And if you get diarrhea, most of the diarrhea is self-limiting and people get better on their own. But if you get diarrhea, you could start with Imodium and then um, keep yourself well hydrated. And we recommend taking Imodium with you instead of buying it in the country so you're not looking for a pharmacy. You're not in a foreign country having diarrhea looking for a pharmacy. That's not a great combination. So taking Imodium with you, and then also we give antibiotics to take with them and not to take unless they get um, diarrhea with some certain things. So if they get diarrhea, just straight diarrhea, and they feel fine, but they're having diarrhea, take the Imodium. But if they're having diarrhea and then they have any kind of red flags, so if they have pain, like abdominal pain, fever, blood or pus on the stools, or they just generally don't feel well, then we recommend taking the antibiotic and consider seeking help. So that's what we give, and we give azithromycin when people travel. We want to make sure they don't have any QT prolongation or any contraindication to taking azithromycin, but that's what we do when that's what we give when people travel. Um, now, um, we do that for adults. If they're traveling with children, we recommend not giving anything to the child and having the child and seeing a pediatrician in that country. The reason is because we're worried about HUS and so children especially can get worse when they take antibiotics. From essentially from the bacteria breaking apart and all the inflammatory stuff on the inside. Um, hurting the kidneys and causing kidney problems, which happens mainly in children. So it's kind of odd, if a parent is traveling with a child, we'll give the adult antibiotics, and then we'll say if the child gets sick, don't give the child your antibiotics. Um, Food poisoning. So when people say food poisoning, this isn't an infection. This is actually a poisoning. So it's due to ingestion of a preformed toxin, not an infection. So if someone gets sick from, their hot dish or their casserole that's been sitting out in the sun, that they waited to take to the picnic for a long time and it's been sitting out, that preformed toxin is essentially, if Staph aureus is growing on the casserole, the Staph aureus is growing and it's secreting a toxin. And then when you eat that toxin, you get sick, but it's not an infection. So you get sick very quickly. In 6 hours or 12 hours, you get extremely sick. You have a lot of diarrhea. You might have vomiting and diarrhea, and then stay hydrated and it all goes away. But because it's not an infection, that means you don't need antibiotics for it. So you just need to stay well hydrated and it will pass. And then I wanted to show, a little bit about non-inflammatory diarrhea versus inflammatory diarrhea. So at the top, it has the mechanism. So I said a little bit earlier about inflammatory diarrhea having mucosal invasion and inflammation, so it's causing damage to the inside of the colon or the small intestine, and that's causing a lot of inflammation and inflammatory response from the patient and symptoms. So fevers are not a major feature in non-inflammatory since they're not having all this inflammation, but in inflammatory, you're having fevers and abdominal pain. And the stool and non-inflammatory, it's just watery and just a lot. So it might be turning on some secretory pathways like cyclic AMP. But over here in inflammatory, you're having blood or pus on the stools and the common pathogens. So non-inflammatory is often from viruses. So they'll get a virus and then you'll have a lot of diarrhea. You may or may not feel really, really poorly because you're not having all the inflammation. You're just having a lot of diarrhea. You might feel poorly from getting dehydrated, but I mean, you're not having high fevers and abdominal pain and everything. And then over here with inflammatory, this is an enteroinvasive, so you're having invasive bacteria that's causing damage to your small intestine or your colon. Now, here are some additional characteristics that I just wanted to show, some different charts and just have these available. So, in case people want to look at it more, but um, we'll keep going. I like showing things in different ways. So here are a couple different charts showing non-inflammatory versus inflammatory and some of the common causes here. Now, non-inflammatory viruses being a big one, and bacteria and parasites, um, and then inflammatory, different types of bacteria that are possibly invasive. Now, as far as the algorithms, there are algorithms for chronic diarrhea and algorithms for acute diarrhea, and I think these are we can look at this a little bit here as far as diagnosis and treatment and management. So diarrhea, greater than 3 loose or water stools per day is how they're defining it here. Assess and treat the diarrhea. So all the patients with diarrhea, no matter what the cause, you want to make sure that they're getting hydrated, that they're not getting really hypotensive, that they're able to keep up with it, meaning they're able to get enough fluids to keep them from getting too bad. Presence of any of the following. So are they having fevers? Are they having blood or pus on the stools? Recent travel? Immunocompromised? So if they're having any of these, are they having any of these or not? So we'll start over here with the no. Symptoms greater than 7 days? Yes. And then it says do a PCR, targeted antibiotic therapy. So if they're having fevers, if they're immunocompromised, if they're blood or pus on the stools, then you want to do a PCR and give antibiotics. So, for example, if they've been traveling, azithromycin might be a good option. Symptoms greater than 7 days, no. Oral hydration, consider loperamide. That's the Imodium I was referencing. So loperamide. Symptoms resolved, yes, and then they're done, no, and then go to A. So you go back up here, you do a PCR test, and you can see that it says PCR or culture. And it kind of depends how sick they are. If they're not too bad, I think and treating would be okay because then, um, the culture will take longer to get back than the PCR. But you would get more information from the culture because you might be able to not only identify it, but also um, see if you can get a susceptibility report. If the patient's already been on antibiotics, then I might lean a little bit more towards a PCR since it will pick it up, but it might be picking up dead organism. But you may not get anything from the culture if you have dead organism. And then if they've had recent travel, are they having bloody stools? Yes, PCR or culture. No, either way, you would do empiric antibiotic therapy. If they don't have any recent travel, fever with or without bloody stools, PCR, empiric antibiotics, targeted therapy, and bloody stool with or without fever, are they immunocompromised, outbreak potential? You want to do a PCR, make sure that you get it identified. So if there is an outbreak, you can identify it and be on top of it. So this is evaluation management of acute diarrhea. I wanted to go through this. I think this is going through something like this is more helpful than going through each and every bacteria and the cause of and the different manifestations. Now, targeted antibiotic therapy for infectious diarrhea with an identified pathogen. So I think this can be helpful because, if it's Campylobacter, azithromycin is first choice. C. diff, you can give fidaxomicin, oral vancomycin. Um, Giardia, yeah, tinazole, but metronidazole works well. Um, so here are some of the different causes and what to give. Um, I did want to highlight E. coli 0157 because as I mentioned before, that if you identify it, then the first question is going to be, do they need treatment? Um, and should I treat or should I not treat? If you treat, sometimes, you know, patients can develop HUS, which is mainly in children. If someone's sick enough to be in the hospital and if they're failing, meaning if the patient's continually getting worse, then I would treat the patient. If if they're improving and they're getting better, then that's when you have the discussion of they're getting better. I don't think they need antibiotics because they're continuing to improve. And this is a best practice statement in GI, and this is um, do not order a comprehensive stool, ova, and parasite exam on patients with diarrhea lasting less than 7 days, no immunodeficiency, no history of living or traveling in an endemic area where parasitic infections are present. So sometimes we see people have a ova and parasite test that's ordered on their stool. So that's where they take the stool, it goes to the micro lab, they put it on slides and they look at it and they try to identify if there are any parasites or parasite eggs. Um, but if they haven't done any travel to a country where they could pick something up, like pick up a parasite, then I recommend not doing that. And potential post-infectious diarrhea sequelae. So sometimes patients will get infections and then they'll get better, but then they'll have some sequelae of disease. So they might get better, but then they might develop HUS, as we were discussing before with children getting antibiotics for E. coli 0157. So they might um, they might get a little bit better and then get worse, or they might just get worse from HUS. Some of these Guillain-Barré is associated with Campylobacter. Reactive arthritis can occur. So these are non-infectious sequelae from infectious diseases. All right, so that's the overview. That's the highlights. You know, this is a good topic. I don't think we've discussed it before, but it's one that was asked for, and I'm glad we're able to go over it and talk about acute infectious diarrhea. Thank you everybody for joining. If you have any questions or anything, you can always email me, and I'd be more than happy to respond to your emails. And as always, I'm always available in case anyone has any questions about patients they're seeing in their facilities and their hospitals to answer any questions and help with any stewardship. All right. Thank you, everybody. Have a good day.